In case of nose, it's DNS and allergic rhinitis, and in case of throat, it's tonsillitis, pharyngitis, and laryngitis. So, what is ASOM? It is acute suppurative otitis media. It is actually the acute inflammation of middle ear cleft, not just the middle ear, but the whole cleft. And what all parts comes in the cleft is the middle ear itself, the eustachian tube, the attic, antrum, adductus, and the tympanic membrane also. It is most commonly seen in infants and children, basically less than 2 years of age, and in low socio-economic groups. It is mainly caused by viral infection. Patient like usually complains of there is a history of URTI infection, which is usually viral in origin, and then there can be pyogenic organism invasion or secondary bacterial infection. What are the routes of infection for ASOM? It's through the eustachian tube due to rhinitis and sinusitis or any adenoid infection or tonsil infection. From the external ear through the perforation. If there is perforation, the organism can enter through there, and bloodborne, which is very rare route of infection. Bacteriology, the most common organism is Streptococcus pneumoniae, found in 30% of cases, then H. influenza, found in 20% of cases, and Moraxella catarrhalis, found in 12% of cases. Other organisms are also found like Streptococcus pneumoniae, Staph aureus, and Pseudomonas aeruginosa. In pathology, talking about pathology of ASOM, actually there are 5 stages. The first is stage of tubal occlusion, then comes the stage of pre-suppuration, then comes the stage of suppuration, then stage of resolution, and stage of complication. Let's talk one by one. So in stage of tubal occlusion, there is edema and hyperemia of the eustachian tube. Basically, the nasopharyngeal end of the eustachian tube is edematous, which causes the tubal occlusion. Because of that, the air is trapped inside the middle ear, which increases the negative pressure, intratympanic or middle ear pressure, which leads to retraction of the tympanic membrane. What happens in case of stage of pre-suppuration? If the occlusion is prolonged, occlusion of the eustachian tube, then there are chances of pyogenic organisms invading, which again causes the hyperemia of the tympanic cavity. And here now the tympanic membrane starts becoming congested. First, the tympanic membrane was only retracted. At this stage, it has become congestion has happening. In case stage of suppuration, according to these stages, even clinical features varies according to the stages. So in stage of suppuration, there is proper formation of pus in the middle ear, which then enters in later stages into the mastoid air cells also. And so in this stage, now the tympanic membrane is starting bulging because there is no, the nasopharyngeal end of eustachian tube is already blocked. So there is no way that the pus will drain from the middle ear. Stage of resolution, what happens? The tympanic membrane ruptures. First, the patient has very excruciating pain in case of stage of suppuration. Then as the tympanic membrane ruptures, there is release of pus and the patient symptoms start subsiding, basically pain. In case of ASOM, there is proper history that the patient will first complain of pain and then discharge. Then you should think about ASOM. If proper treatment is started at this point, like first antibiotics were not available, that time this stage used to happen, but now antibiotics are available and we start the antibiotics at the stage of congestion only. So it's very rare that tympanic membrane ruptures and patient comes with that history. Stage of complication, it depends on the virulence of the organism. If the virulence is high or the resistance of the patient is very poor, then the resolution stage does not take place and the stage of complication occurs. What happens basically in stage of complication? The pus starts going into the mastoid air cells. Once the pus starts going into the mastoid air cells, the following complications like acute mastoiditis, subperiosteal abscess, facial paralysis, labyrinthitis when it enters into the inner ear, petrositis when it enters into the petrous apex, extradural abscesses, meningitis, brain abscess, lateral sinus thrombophlebitis. Now let's come to the second common finding in ENT OPD, which is chronic suppurative otitis media. Actually, it is the long-standing infection of the part or the whole of the middle ear cleft. There is complaint of ear discharge and a permanent perforation. Patient may or may not complain of ear pain in case of CSOM. There are two types basically, tubotympanic or safe or benign or mucosal, and the other is eticoenteral or unsafe or dangerous or squamosal. Basically nowadays the mucosal and squamosal, this is the classification used. Other terms are usually not used. Then coming to the pathology of, first we will see the mucosal type. The mucosal is obviously localized to the mucosa, which is the anterior-inferior part of the middle ear cleft. It is actually the process of healing and the destruction which goes hand in hand. Either of them can overtake the other one, depending upon the virulence of organism and resistance of the patient, of course. Then perforation of the tympanic membrane, it can involve the pars tensa or pars flaccida. Pars flaccida basically composed like behind the pars flaccida there is etic area. So therefore it's called as etic perforation. Pars tensa, there can be a central perforation and a marginal perforation. What does central perforation means? All around it is surrounded by a layer of tympanic membrane. In case of marginal perforation, there is no layer of tympanic membrane. It can be annulus also, or there can be destruction of annulus also. So central perforation is classified as anterior, posterior, inferior, subtotal according to the position of handle of malleus. If it is anterior to the handle of malleus, then anterior. If posterior, then posterior. If inferior to it, then inferior. In subtotal, it is a very large perforation of pars tensa, where parts of pars tensa and or annulus of tympanic membrane are still preserved. Whereas in total perforation, no part of pars tensa is preserved. Marginal perforation, perforation destroys even the annulus and reaches the tympanic sulcus. It may be posterior superior, anterior, inferior, or total, and pars flaccida. Basically, the marginal perforation and pars flaccida perforation, these come under the squamosal type, the unsafe type, and the central perforation comes under the mucosal type. Then you have to look for the middle ear mucosa. From the perforation, you can see middle ear mucosa. If it is normal, that means the disease is in the quiescent stage or inactive stage. If the disease is very much edematous and velvety mucosa, that means the disease is active, or the patient may complain of active discharge from the ear. Then comes the polyp. Polyp is basically smooth mass of edematous and inflamed mucosa which protrudes through the perforation in the external auditory canal. The mucosa of the polyp can be pale, usually in mucosal type. In mucosal type, very rarely we see the polyps. It's usually present in the squamosal type or the unsafe type when the polyp is fleshy and edematous. The polyp can be attached anywhere. It can be attached to facial nerve also. So we have to be very careful. Then comes the ossicular chain. It is usually intact and mobile, and there is some degree of necrosis, most commonly the long process of incus. Why the long process of incus? Because the blood supply is very less to the long process of incus, so it will be the first from all the ossicles to get necrosed. Then comes the tympanosclerosis. It is hyalinization and calcification of the subepithelial connective tissue. What you can see on otoscopy or endoscopy, there are white chalky deposits. If the perforation is large, we can see the deposits even on promontory and ossicles, or after opening the ear during surgery, we can see it on joints, tendons, oval window and round windows. What does this white chalky deposits or tympanosclerosis causes? It interferes with the mobility of the structures. So the resulting thing is patient has deafness, which is conductive deafness. Then comes the fibrosis and adhesions. It is actually a part of the healing process which leads to impaired ossicular chain mobility and block the eustachian tube. Types of, we'll see the classification of chronic otitis media. As I told you, now only the terms mucosal and squamosal is used. In mucosal, there can be active mucosal disease, which means the patient is complaining that there is discharge. We can see discharge in the external auditory canal. Inactive, the perforation has become permanent and healed, which is adhesive otitis media. In case of healed perforation, the margins of the perforation, there is formation of the layer, the squamosal, which is the outer part of the tympanic membrane from the three layers of the tympanic membrane. When the squamosal part, the outer part, starts entering the inside or starts covering the other two layers, the fibrous and mucosal layers, then the mucosal disease becomes permanent. Then comes the squamosal. In squamosal, there are retraction pockets. in pars tensa or pars flaccida, or there can be atelectic ear, means the tympanic membrane is totally adherent to the promontory, and on valsalva there will be no movement of tympanic membrane. In active squamosal disease, there is cholesteatoma with discharge. These are the various types of perforation. Central, all are central basically, but it's anterior, and then medium-sized perforation, small. Small means involving only one quadrant, medium means two, large means three. Actually, there are four quadrants of the pars tensa. According to that, this classification is there. Then subtotal perforation, then total perforation with destruction of even the fibrous annulus. This can come under squamosal also. Then there is attic perforation and posterior superior marginal perforation. Then coming to the pathology of squamosal type, basically squamosal means cholesteatoma, which can be classified into congenital, primary and secondary, which are acquired. Osteitis and granulation tissue is present. Osteitis involves the outer attic wall and the posterior superior margin of the tympanic ring. Then there is granulation tissue which surrounds the area of osteitis. Granulation tissue is basically the healing process has started taking place, and granulation may fill the attic region, antrum, posterior tympanum and mastoid also. And the polyps in this are fleshy, red, velvety, which may fill all the meatus, external auditory canal. Then ossicular necrosis, destruction of the long process of incus is the first to involve, as usual due to a vascular nature of it. Then stapes suprastructure is most commonly involved, followed by handle of malleus, and then entire ossicular chain can also be involved in more severe types. So in this squamosal type, the hearing loss on audiometry you will find there is greater. Even the patient complains that there is hearing loss. There's something called as cholesteatoma error. You are suspecting a squamosal type because some attic perforation or something like that. But the patient is not complaining of hearing loss at all. Then you can suspect that the cholesteatoma is bridging the gap between the ossicles. So the sound conduction is happening through the cholesteatoma and the remnants of the ossicle. Therefore, the hearing loss is not apparent. Even on audiometry, the hearing can be, as the patient is saying, not much hearing loss. Then comes a cholesterol granuloma, which is mass of granulation tissue filled with foreign body giant cells, which is surrounding the cholesterol crystals. It is actually a reaction to long-standing retention of secretions or hemorrhage. Then third comes the otitis media with effusion. This is also very commonly seen in ENT OPDs. The various names are serous otitis media or secretory otitis media or mucoid otitis media or glue. It is basically accumulation of non-purulent effusion in middle ear cleft. Non-purulent means we are not suspecting bacterial infection. It is sterile. We usually do not prefer antibiotic in these cases. Pathogenesis, it's the malfunctioning of the eustachian tube. The eustachian tube fails to aerate the middle ear, and so there is no drainage of the middle ear fluid. And increased secretory activity of middle ear. There is increase in number of mucus and serous secreting cells. This was observed after histopathological examination in cases of otitis media with effusion. Then coming to the nose, DNS, which is deviated nasal septum. This is also very common in ENT OPDs. Basically, first let's see the anatomy of the nasal septum. The medial part consists of the septal cartilage and then the perpendicular plate of ethmoid, vomer. Then there is crest of maxilla and the crest of palatine bone. The most common cause is trauma. It can be lateral blow, which will cause the displacement of the septal cartilage from the vomerine groove and the maxillary crest. Then blow from the front, it will cause buckling or twisting of the nasal septum. Fractures, duplication of the nasal septum with telescoping of its fragments. Also, DNS from birth. If the patient has DNS from birth, it is due to trauma during birth, during the normal delivery, the passage. It can obstruct or cause pressure, leading to deviation of the, because during in children it is like cartilage basically, so it can be turned just by the pressure. There can be developmental error. How nasal septum is formed? It is the descent of the tectoseptal process, which meets the two halves of the developing palate in midline. Then during primary and secondary dentition, further development of the septum occurs. Then there can be unequal growth between the palate and the skull base. This will cause basically the buckling of septum. In adenoid hypertrophy patients, we see high arched palate. Therefore, since patients are mouth breathers, the palate of these patients become very high arched. In those cases also there is septal deviation. In cleft lip, cleft palate and dental abnormalities, DNS is usually present. So this is DNS associated with high arch palate. We can see the S shape of the DNS. Racial factors like Caucasians affected more than Black Americans. Hereditary members of the same family can have present with same complaints. These are the various types of deviated nasal septum. There can be anterior dislocation, C-shaped, where patient will complain difficulty in breathing from one side. S-shaped, where patient will complain that I have bilateral nasal obstruction. Then there is nasal spur impinging on turbinate. Usually such cases present, the most common complaint is headache. Then there is thickening of nasal septum in case of abscess or any blood between the two layers of the septum. Then coming to next thing is allergic rhinitis. It is basically IgE-mediated immunologic response of the nasal mucosa to airborne allergens. It is characterized by there is watery nasal discharge, nasal obstruction, sneezing, itching in nose, eyes, itching in palate and pharynx. Two types are seen: seasonal, during particular season like season of pollens, the patient complains of having all these symptoms. Perennial, whole year, the patient says मुझे 12 ही महीने problem होता है. Coming to the pathogenesis of allergic rhinitis, we'll see the structure of IgE antibody. It consists of a Fab end, Fc end, heavy chain and light chain. Then there's mast cell. The antibody antigen complex gets attached to the mast cells, which due to the attachment there are release of mediators. There can be preformed mediators and newly synthesized mediators. The pathogenesis of allergic rhinitis, clinical allergic response can be acute or early phase. The patient will present within 5 to 10 minutes of exposure to anything like pollens or something like that. It is basically due to release of vasoactive amines like histamine. Then there is late or delayed phase, which occurs after 4 to 8 hours of the exposure, and it is due to infiltration of inflammatory cells. So what happens when the antigen antibody complex gets attached to the sensitized mast cell? There will be release of mediators, as we have seen in the previous diagram. There can be release of preformed mediators and newly synthesized mediators. What all mediators are preformed? Histamine, ECFA, NCFA, heparin and others. And newly synthesized mediators are prostaglandins like PGD2, leukotrienes, PAF, thromboxane A and TNF alpha. So what does histamine cause? These all mediators are responsible for the symptoms which patient presents to us. Like histamine will cause vasodilatation and bronchospasm. Eosinophilic chemotactic factor of anaphylaxis, it will attract the eosinophils to the site of reaction. In the similar way, neutrophil chemotactic factor will attract the neutrophils. Heparin will enhance the phagocytosis. Prostaglandins, they are vasoactive and bronchospastic. Even leukotrienes are vasoactive and bronchospastic. Then platelet aggravating factor, histamine and serotonin are released from platelets, causes chemotaxis of neutrophils and eosinophils. Thromboxane A is spasmogenic, and tumor necrosis factor alpha, it helps transmigration of neutrophils and eosinophils and attracts them where the site of reaction is happening, that is mast cells. So there can be specific allergic stimulus, which is IgE mediated. Then there can be non-specific stimuli like weather change, especially in monsoon, this time period, humidity, when the humidity is very high. Then emotional stimuli, salicylates, various viral infections and air pollution. They will go and attach to the mast cell or blood basophils. Then there will be drop in cyclic AMP and cyclic GMP ratio, which will lead to release of those all preformed and newly formed mediators. What it will cause? Increased vascularity and permeability and vasodilatation. So there will be tissue edema, which will lead to the nasal blockage complaint in patient. Then there is change in the smooth muscle tone, which will cause bronchospasm and patient will complain of difficulty in breathing. Then there is hyperactivity of glands, which will lead to increased secretion and patient will complain of rhinorrhea. watery like nasal discharge from the nose. Then coming to tonsillitis, acute tonsillitis and chronic tonsillitis. So first let's cover acute tonsillitis. Tonsil consists of surface epithelium. Then there are crypts and lymphoid tissue. The crypts, there are two types of crypts, primary and secondary. At the beginning, they are primary, and when the primary branches, those are the secondary crypts. And crypta magna is the first crypt, the most prominent, which you can see even while operating tonsil patients. Then there are various types of acute tonsillitis like acute catarrhal or superficial tonsillitis, acute follicular, acute parenchymatous tonsillitis, and acute membranous tonsillitis. It usually affects school-going children, and the most common organism found is hemolytic streptococci. Others can also be seen like staph, pneumococci, or H. influenzae. What are the complications? Now coming to the chronic tonsillitis, it is basically complication of acute tonsillitis. If acute tonsillitis is not treated well, or if the patient takes inadequate dosage of antibiotics, then the acute tonsillitis can get converted into chronic tonsillitis. The microabscesses walled off by the fibrous tissue, this all is seen in the lymphoid follicles of the tonsil. It is seen in children and even in young adults. The predisposing factor is chronic infection in sinuses or any tooth decay history. Then what are the types of chronic tonsillitis? It is chronic follicular tonsillitis, chronic parenchymatous tonsillitis, and chronic fibroid tonsillitis. This is the case of parenchymatous tonsillitis. The two tonsils are almost touching each other. So patient complains of there is a difficulty in deglutition, speech, or respiration. There are various grades of tonsillitis. This is grade 4, touching each other. Then comes the laryngitis, acute laryngotracheobronchitis. As the name suggests, it's the inflammatory condition of larynx, trachea, and bronchi. It is due to viral infection which is caused by para-influenza type A1 and 2. Most commonly affecting children from 6 months to 3 years of age, and males are more commonly affected. It is said that males are more commonly affected because they play outside and all the dust and all that goes and settles in the trachea and all that. Therefore, then secondary bacterial infection can also happen, which is most commonly due to gram-positive cocci. What will happen in laryngitis? There will be in the subglottic region, that is the loose areolar tissue, it will swell up, which will lead to respiratory obstruction and stridor. There will be thick tenacious secretions and crust, which will also occlude the airway. It can be chronic laryngitis, which can be diffuse and symmetrical, or a localized process. When it is localized, various diseases patient can present with these all diseases like dysphonia plicaris ventralis. Then vocal nodule can happen, vocal polyps can happen. There can be Ranke's edema involving the Ranke space, and contact ulcer. Contact ulcer means the contact point when the vibrating vocal cords touch each other, which is usually the anterior 2/3 and the posterior 1/3 point. Pathological changes start in the glottic. There are 3 parts, as we know, supraglottic, glottic, and the subglottic. So basically, it first starts in the glottic area, which will extend to the ventricular band. Ventricular band is basically the band between false and true vocal cords. Then it will extend to the base of epiglottis, which is a supraglottis area, and then come down to subglottis. There will be affection of mucosa, submucosa, mucous glands, and in very severe cases, intrinsic laryngeal muscles can be involved, even the joints like cricoarytenoid joint. In the submucosa, there will be hyperemia, edema, and cellular infiltration is seen. The pseudostratified ciliated epithelium of the respiratory mucosa, it will turn after infection, it will turn to the squamous type. And the squamous epithelium, which is of the vocal cords, there will be hyperplasia and keratinization. In mucous glands, there will be hypertrophy first. Later, there will be diminished secretions and dryness of larynx. That's it. Thank you.